The problem is apparent. We have approximately 50 million people in this country without insurance. We also have premiums going up annually, typically on double-digit basis. We typically see medical costs going up, which are passed along in our insurance premiums. How do you solve these problems? So-called Obamacare is intended to address that, but it won't put everybody under insurance. And of course, it's being fought over on many fronts at the moment, from mandates on from there. Former Governor Philip Bredesen, to my right, has a book called Fresh Medicine, which offers a completely different approach to resolving healthcare, and we're going to talk about that today. Governor, thank you very much for joining us.
Thank you, I appreciate it.
So, just to lead off, you have some positive words about the healthcare reform that's in Washington, but you're not a big fan.
No, I'm not. I'm a Democrat and Democratic governor, and a very strong supporter. I believe in what President Obama is trying to do in general. I think they just really missed it on healthcare, and what I'm trying to do in the book is to point out where, but keep that to 10% and spend the other 90 on where we really ought to be going, stepping back a little further in the long run. You know, my concerns are twofold. I mean, first of all, I think it's a very complex system that adds complexity and layers of complexity on top of something that already is too complicated. It does nothing to really address costs in the long run. If you bend the curve by an extra 0.5%, which is what the goal is, you still have an unsustainable system. You know, we talk about all these issues of the deficit today. Remember that Medicare alone, our old age program, currently has a $37 trillion present value of benefits we've promised to pay but do not have taxes collected or on the books to do it. That dwarfs the other kinds of things that we're talking about. And as I said in the book, it just seems to me, my disappointment is, you know, when the conditions are right, that's when you do the difficult things. And it's hard to know how conditions could have been more right than when President Obama took office. I mean, there was this desire for change. You had a charismatic, articulate president who could to put something on the table. People were saying, tell us what to do. It reminded me in a way of the time after 9/11. I mean, there was that 3 or 4 month period where people in the country were ready to follow the president just about anywhere. That's where I felt we were. And instead, we expanded coverage, and that's fine. I mean, it's great that 32 or 34 million more people have some additional coverage. We're still leaving 20 million people uninsured in this. And we didn't do any of the tough things or start things underway that are going to happen over the long run.
So with the president's approach is, for all of the high rhetoric and for all of the high ambitions, once you go up against entrenched interests, it became very difficult. And watching the public option come into view and then leave the picture is, I think, symptomatic of efforts to change this system. You're coming forward with an approach that's radically different from what's on the table right now.
Yeah, it may be it's different from what's on the table, and you know, we can talk about it. But the pieces of it are things that are already around and accepted. I mean, I talk in here about. I mean, what I'd love to see is to use something like Social Security as the model. Where it truly is a universal system. You get a basic level of health care in this country if you are walking and breathing. The way we pay for it is some sort of a payroll tax or some dedicated trust fund-like approach to the thing. With health care, it's got to be more graduated than it is in Social Security to make it work. We just sort of cut through 9 million different kinds of subsidies for different kinds of people, cut through that whole thing, break the thing loose for basic care from the employer market, which is that's an artifact of how healthcare got started in the 1930s, how health insurance got started, and just turn it into something which really is American, that is owned by the people of the country and not by your employer or some government program or something else. You know, Social Security as a model, you know, I think is really interesting. It is a very popular program. I mean, it's politicians touch. It's the third rail of politics, as you've heard it called, and people touch it with great difficulty. Even though most people pay more in Social Security taxes than they do in their federal income taxes. It's not the sort of thing that the Tea Party is around talking about how we need to undo Social Security. And I think the essential element of Social Security is it doesn't read like government. I look at my Social Security and I think of it, that's something that's mine. I pay into it during the time that I'm employed, and my employer does as well. I own it. When it comes time for me to collect, it's not government largesse, which is dependent on the Congress saying it's okay for me and my demographics to get this. It's mine. And I'd like to make healthcare the same way, break it loose from what I see as a kind of a paternalistic system for providing healthcare into something that really empowers individuals with it.
Let's get into the specifics of this. So you create a Social Security-like trust fund, which would be our healthcare trust fund. It's paid for primarily by payroll taxes.
Well, what I've said in there is I've talked about payroll taxes. You can also put a component of an income tax in there. Again, one difference between medical care and Social Security is that medical care costs the same for somebody who makes $30,000 or somebody who makes $300,000. Unlike Social Security, where the payout is different in those cases. So it has to be a more progressive kind of system. So you have to design that. Whether that's designed around payroll taxes, whether that's designed as a component of an income tax or other kinds of things, that's something that's got to be, obviously, that has got to be worked out. But I'm saying something that when you are employed or making money, you put money into this system. When you're not employed and not making money, either because you're a child or a dependent or retired or something else, is when you take out your share of the system. And you just cut through all of this stuff about means testing and everybody having to apply and exchanges and all this other kind of stuff, and just turn it into a nice simple system.
And yet, when you write in the book that we're talking about a potentially 20% payroll tax, tell everybody why they shouldn't be afraid of that.
Yeah, I just said, my point was, I said, if you figure the numbers to do it, it would take about a 20% payroll tax to do that. Well, that sounds shocking, except for the fact that most people are already paying that much in for their health care. I mean, the combination of what your employer is putting in and what you are putting in as whatever is, in many cases, typically a number which it might, and for a lot of people, would be considerably larger than that. There are a lot of people at the lower end of the economic spectrum who, under something like this, end up better. End up better off.
But does my employer contribution persist? Because right now, my employer picks up about 75%.
Well, what I'm saying is, right now, if you're employed and your employer provides insurance, the employer is putting in, the national average is around 72 or 73%. It depends, obviously, all over the map in terms of the deal, but they're putting in 3/4 of it. You're putting in roughly a quarter. Okay. Well, a Social Security payroll tax is a 50-50 individual and employer tax. So fine, you structure it as a 75-25 tax. It's a tax, and 15% of it's paid by the employer and 5% by the individual. If you want to graduate it, it's a lower number on the first $50,000 of income, and higher, after that up to some limit. You can structure that. But my point is, it almost seems counterintuitive that you could cover more people with that. But remember also, you're bringing a lot of people now into the system through this who are not in there now. I mean, all of these people who are working for small businesses and who are uninsured and all that are not contributing. They are contributing into the Social Security system, but they're not contributing into the medical care system today. So you're also bringing other sources of revenue into it as well. But the essential idea is, say, look, let's think about this in trust fund terms, that we're setting up a fund, we're going to put a certain amount of money in the fund, and we're going to pay these things out of the fund. We're not going to, as we're starting to do even with the Social Security now, we're going to keep the fund honest. If you want to argue about whether X should be covered, that's a great argument to have, as long as it also goes along with the side of, and here's the implications for what we're going to have to put into the fund, to get some economic reality into it. If it costs nothing, of course, everybody wants everything. People make intelligent choices all the time about how they spend their money. You can decide to take your money and buy a nicer house, or send your kids to a better college, or take more vacations with your family. I mean, these are important choices. Buy more health insurance. People make these decisions all the time. We're very capable as people of doing that.
We create the trust fund, and out of this big pool of money into which we have all contributed, we will all now take a slice in the form of vouchers?
Yeah, I think the voucher idea is kind of the way it works. You can't really write somebody a check because they won't use it in many cases to buy health care. And then we're still going to take care of them when they get in accidents and have bad things. But you basically have a voucher that comes out of it. Those things, those vouchers, in terms of their real value, are obviously adjusted for age and some of those other kinds of things. But basically, what I want to do is to get the money together in a fund and then basically pin on everybody's lapel in the country this voucher that says you can go decide from whom you wish to buy your health care. It's not who your employer decides they're going to offer. It's not anything else. You can decide where to go and get this care.
All right, well, since, as in all cases, this is really all about me, here I am sitting here with an insulin pump on.
I didn't know you were a politician.
No, I should be. I have a lot of medical costs. I'm an active user of the healthcare system. This little device keeps me alive. I am expensive compared to someone who is not a diabetic.
Right.
Does that mean I get a bigger voucher? Is that fair that the person next to me who has been paying roughly the same amount into the system is now going to be getting less out of it than I'm getting out of it?
I think when you start something like this out, you need to adjust the amounts of these vouchers in some way for health status. Okay, and I'm saying fairly rough, not some very fine thing, to prevent the kind of adverse selection. When you start, everybody goes and tries to find all the healthy people. The other thing is that I would very much like, we'll talk in a minute, I'm sure, about this idea of systems of care, which is the other foot to this stool. But in my view, you want these systems of care built around existing medical operations and centers. I mean, I think a big tertiary care hospital complex is the beginnings of a really good integrated systems of care with its associated faculty practices and those kinds of things. And those people are everyone who is sick is going to be very familiar with those, and so they tend to join that system. So you've got to adjust for it. Over the longer run, I think you really can remove that. I mean, when you're born, you then start through life, and you may have various issues or not issues throughout life. The systems of care, I mean, obviously they're required to take those people who apply to them up to whatever their limit is. So you get a chance to pick where it is you want to get your health care.
Before we go deeper into systems of care, because you're right, that's very important, I just wanted to focus a little bit more on the voucher. And that is, unlike Social Security, where everyone gets a retirement check commensurate with what they paid into the system, under your system, those in greater need or in greater potential need of health care are going to get a larger slice of the pie.
Yeah, and they're going to. It's even. There's two ways in which it's different. I mean, first of all, it is insurance in the sense that there are some people who are going to have much larger health care costs than others, and part of that leveling is that's what insurance does. You also buy auto insurance, and I presume you either have more or fewer auto accidents than the average. You've had none, fine, so you're paying a lot in auto insurance, and that's different. Even more striking, though, I think, is the fact that economically it's different in that someone who makes $30,000 a year gets a much larger advantage out of this than someone who makes, let's say, $300,000 a year, which is the big difference with Social Security. And I really think it's inevitable in healthcare because the stuff, it really does cost the same for someone at $30,000 or $300,000 to have these various kinds of treatments. So that is a fundamental difference, and you really, if you're going to make any kind of a healthcare system work, you have to have some subsidy of lower income individuals.
Now we're going to get into systems of care. That's a highfalutin phrase. It sounds a little intimidating, but what we're really talking about is essentially a group. The governor says that it's centered around a medical center, for example, that's going to be the healthcare provider. Here's one of the most satisfying things about your proposal. Let me ask you this. What happens to health insurers?
I think most health insurers kind of go away. Remember that there's health insurers were made the villains in this last round of reform, which I'll be honest with you, I do not think did not think was fair. I mean, I love good political theater and all that, but the problems that they present, I mean, the high administrative costs, they're much more built into just the notion of we've got this big complex fee-for-service system that everything you do has got a billion blizzard pieces of paper going around. It's an expensive system. But in a system like this, they're an intermediary that goes away. I mean, this whole idea of an insurance system for something that is no longer insurance has got nothing to do for most things with what insurance is about. Insurance is when your house might burn down one time in 1,000 and you pay into a pool, so if it does, you get burned down. It's extraordinary events, well-defined events you take care of in insurance. Healthcare is not like that at all. This room, I'm sure, is full of people who've got monthly healthcare expenditures, very predictable healthcare expenditures. And we've preserved this model, though, of doing that, and this cottage industry model of how healthcare is delivered that just is very inefficient and uncoordinated. And we spend money on things like information systems to try and make it better coordinated. I'm just saying, let's step back from the whole thing and say, no, it's a silly way to pay for these things. Let's just break that down, give our check to a system of care, which is responsible for providing all the care and for the quality of that care, and just cut out this complexity in the middle of the system.
Okay, so continuing our theme of this being all about me, my healthcare is based at UCLA. Mm-hmm. Does UCLA become my system of care? And it in turn not only provides the treatment, but it is now going to be what had been my insurer.
Yeah, I don't know. I would suspect that in every area with this, and I've talked about it in some detail about how you might put it together, that there would arise some systems of care. In Nashville, where I'm from, Vanderbilt University is there. They have a big complex medical center. I feel certain Vanderbilt would become a system of care. Now, they're not complete. Vanderbilt's not very good in primary care, and they'd have to expand over there. There's a big competing set of nonprofit hospitals in town. They probably would as well. HCA has got several hospitals in the area. They probably would. And Blue Cross is strong in Tennessee. I suspect that while they're not a direct deliverer of care, they'll try to figure out some way to become this. So I think what you end up with in some place like a Nashville, is 3 or 4 of these systems of care that you choose between. In a Los Angeles, there would obviously be more, and UCLA might well be one of them.
USC, Kaiser, Cedars-Sinai, and these might be the nucleus.
Yeah, and others, people may say, I don't choose to become a system of care, but I've got unique things. What I'm going to do is work with these systems of care to provide specialized kinds of services that might be needed or something like that. But the essential point is the working with them economically is a contractual arrangement with them, not I get to do whatever I want and then send little slips of paper over to be paid.
The patient side of this is to how the patient will be interacting with the system. How does the system reduce costs?
I think there's 2 things here. First of all, remember that you're talking in a system of care that through these vouchers, you're going to constrain the amount of money which is going into it. You're sort of saying to somebody, this is how much money you're getting, and you do have the requirement to provide this base level of this base level of care of these things. You're going to have to figure out how to do that. Now, what will happen is that some will and some won't. And today, people complain about, I don't have enough money to provide the health care. People are going to die in the streets because of this. Under this alternative model, that's awfully hard to say because there will be plenty of places in the country, and particularly in a region, who are doing just fine with this. They figured out how to make it work. But by we're never going to constrain the costs of health care so long as it's an open-ended checkbook on whatever the trust fund is. Every country that has managed to constrain this in some way, including ones that have got better quality of care than we have, one of the things they do is in some way constrain the total amount of money that goes into the system, that it's not simply we pay everything that comes along. And this is a way of doing it. Now, you can adjust that. If you don't like the result, the Congress can adjust that. You can change the total amount and the growth rate and those kinds of things. But there is so much. Remember, we're at half again in GDP terms the cost of care of any other country in the world. And in dollar terms, it's almost twice. I mean, it's not like there is no room to push back on these things in American healthcare. So fine, let's constrain the amount of money. Let's get the economy working for us. Let's get the Drucker School producing people who are helping UCLA's find better ways of providing this care and organizing the care and putting it together. We've got this great economy in this country. It's very productive, it's very efficient, it does a great job of creating value. Let's apply it to healthcare.
I'm fuzzy on this. We spend approximately $2 trillion a year in the United States on healthcare. We spend twice as much per person in this country than most other developed nations. Right. And yet we have higher infant mortality and shorter lifespans here. We're not getting a lot of bang for our buck. When you talk about constraining the funding for this, what exactly are you saying?
What I'm saying is if the underlying rules are that a system of care has got to provide, and we have not talked yet about the third component of that, which is the quality measurement.
We'll get to
that. But if a system of care has got to provide a certain level of care to you, and its quality is being monitored and publicly reported, their job is to figure out how to do that within the constraints of the money that you have, how to allocate the resources. I suspect one of the things that will happen in that way is that you really will see a shift away from all of this expensive specialty stuff and back into some of the front end stuff that is less expensive and does a much better job. Remember that some of the places, it's not just infant mortality that we've got quality issues in this country, but it's in simple things like if you've got diabetes, you ought to have an eye exam once a year.
Thanks.
Okay. But I'm just, you were talking about that, but you ought to have an eye exam once a year. In this country, half of the people get it. It's not expensive. It can be done in the doctor's office. And the reason is there's no money in that. I mean, it's just a little side thing that the doctor is supposed to do. But half people don't get it. Now, if you end up with macular degeneration or whatever comes out of not having those kinds of things, we're really good about having laser surgery and lots of other things at the back end. But any rational system of care is going to be moving money back up to the front end and the preventive end and the primary care end and some of these softer things that are better for the patient and they're better for the cost of the system. The only thing they're not better for are subspecialists who are doing this stuff and making a lot of money doing it.
But if we put a lid on spending, what prevents the healthcare systems from a rush to the bottom in terms of the service provided?
Because remember, we're going to create a competitive environment. I talk about Nashville again, where I was there. Again, what the third piece that I want to do with this is for every one of these systems of care to have a formal, independent quality assessment and monitoring and reporting system. And I actually argued in here it ought to be a single number. Okay, Vanderbilt University System of Care 87. The St. Thomas, that's the big nonprofit in town, System of Care 85. The fly-by-night Veterans Healthcare System of Care 52.
This is a quality number.
It's a quality number
per a national standard.
as per evidence-based medicine, which everybody agrees ought to be applied to these kinds of things. So what happens now is if I'm Vanderbilt and I race to the bottom, and suddenly the score is 75 and my competitors are 87, you're going to have an awful lot of people who will move from Vanderbilt to a higher quality thing. I mean, when people have the freedom to make their choice among the different systems of care, and they've got usable information, a single number, and maybe something about some of the sub-areas you might be interested in, but a single number, they'll make that choice based on several things. I mean, convenience and where it's located, but the quality score is going to be a huge component of that. Most people are not going to go to a very low quality or much lower quality system. So I think actually Vanderbilt really is now under a lot of pressure to figure out, I got to make this all work within the constraints of the voucher, okay? But I got to have really high quality numbers or I'm going to lose people to St. Thomas, which is working on that. That's the economic tension you want to create. I mean, that's what makes goods and value in the economy in this country.
Now, as a corollary to the quality audit, there's the question of the service that the healthcare provider is going to be offering. When I was diagnosed a few years ago, one endocrinologist wanted to put me on a monastic diet. Another one said, "You're going on insulin, kid." How does your system create a uniformity of healthcare to create the economies of scale we're looking
Yeah, I said
for?
the piece of this you need to make systems of care work is a real quality assurance system in healthcare. We don't have that today, and it is not rocket science. It's something that lots of people have learned how to do. I mean, it's real straightforward. If you want a quality assurance system, you first of all have to have a set of standards. And then you got to have some way of independently auditing and working against those standards. What we have today is very late and sort of ex post facto measurement. It's like, when you build airplanes, we don't say to Boeing, will you let your engineers and your riveters and your welders do whatever they want in their professional judgment, and we'll measure how many airplanes crash 10 years later from now and tell you how well you did. Instead, you go back, you put standards in place, you say, this is what we know about riveting an airplane here in 2011, and we want you to conform to that. And when an airplane crashes and it turns out there was a problem with the riveting, fine, you change the standards for the riveting to get rid of those kinds of problems. So in healthcare, to me, that means what I talked about in the book is say, look, first of all, we got to set these standards. There are areas where there's a lot of common, I say, agreement, and diabetes is a good example. There's pretty common agreement about what are the main things you ought to do with this. Set these standards and write them down. And it's got to be done by somebody with the imprimatur to make it count. And I've talked about setting up a national panel and commission to do this. There's lots of areas of healthcare where there is not agreement on this stuff. Well, fine, that's an indication that we ought to be doing more research. We ought to be working on some of these things. I mean, in the whole area of mental health, for example, there's almost no standards out there for appropriate and proper treatment of these things. If someone is, diagnosed in some of these areas, there's a million different ways in which they're treated. There's lots of even simple things. What doctors have told me, for example, are things like if a patient comes in with back pain, lower back pain, there is nothing to guide us. We're all, some people do CAT scans and some people do MRIs and some people do this and that and the other. Well, there's some answer as to what a consensus of good physicians think ought to do this. And if there isn't, there ought to be some research done to figure out what that is. You put those all down, and then what I propose is fine. You set up and you spend a little bit of money on a quality audit where these records are constantly audited, and there's now real pressure on these systems of care to do what Boeing has to do when they build cars, or VW or somebody has to do when they build automobiles, which is incorporate this stuff in day to day that we're following these standards. In healthcare, you always leave plenty of room for professional judgment. I don't want my doctor to be doing, a cookbook kind of medicine on me. But if a doctor is going to deviate from the standards, they ought to at least make a note as to why it's not appropriate for you. And you'd have a lot of respect for those. You have a lot of respect for those things. But I just really think that healthcare badly needs some objective quality assurance out there, because individual patients are not in a position to judge that, obviously. And there is a lot of information. Everybody talks about evidence-based medicine being important. I'm just saying that's fine. I agree. Let's give it some teeth. I mean, let's really write it down. Let's measure it, and let's report it.
You talk in the book about the creation of something that you call the Red Book, which would basically be a phone book of standard practices that we know about, put together by the panel that you go into detail in here. This is one of the more controversial aspects of your proposal, because this panel will essentially be defining medical treatment in the United States. You talk about how you would constitute it, but it strikes me that this is one of the areas where politics and ideology is going to creep into the process. How do you remove these experts? Do you create a sort of Federal Reserve of medicine that would oversee this sort of thing?
What I suggested in here was setting up a group which had some representation from not interest groups. This is not the place where you want the manufacturers of medical devices to have their say, but of people who would have some expertise from different perspectives. And people at academic medical centers, certainly, there are certainly business people and people in research who could do this. And you do it with a soft hand. I mean, you're not trying to go in and say, this is absolutely the way you treat. I talked about it more, and the example I actually used in here was about diabetes. How do you set up a little bit of a dashboard that I'm not defining exactly how you treat diabetes, but there are some things we know. There's the blood glucose level ought to be in these ranges if you're managing it properly. You ought to do an annual eye exam. You ought to do a foot exam. There's softer things. There ought to be a piece of paper somebody walks away with, and in a language appropriate to them, or some other way if they can't read that tells them how to do that. These are all components. Let's measure those things and report them. And I think when you do that, you'll start to see that 50% rate go up in a hurry, because it's easy to do, it's cheap to do, it has a huge effect. At the moment, there's no money in it for anybody, so it doesn't get done.
We see all the pieces starting to come together. Let's go back to the funding now, the trust fund. I was reading in the paper just today, again, about how Social Security is running out of money, how we're now paying out more than we're taking in, and how the whole question of the government IOUs and all of that. What makes your trust fund better than the Social Security trust fund?
Hopefully when it's set up, it will be set up a little more firmly. Look, the Social Security trust fund, there is no difficult problem there. Anybody who goes to school, to college, and takes an actuarial course or two and gets a B can figure out exactly what the costs of Social Security are going to be for a long time in the future. The only thing we lack is the political will to either change the benefits or change the taxation that it takes to put the money into the trust fund. Social Security is a non-problem. The Congress can solve it tomorrow afternoon if they want to. Healthcare is much more difficult because it's such an open-ended process where you can't define the costs accurately in the future. But in Social Security, the only problem with that trust fund is a lack of discipline in the trust fund.
But Governor, you just correctly pointed out that the solution to Social Security is less benefits, more taxes, or both. When the healthcare trust fund starts running into trouble, are we talking about the same thing? Higher taxes,
Yeah.
Less benefits? Healthcare seems like a slightly different critter than retirements. The stakes are higher.
That is true, and if the amount of money which is in the voucher, for example, proves to be inadequate, okay, well, fine, the Congress changes it.
Raises taxes.
Or in that particular case, it'd be raises taxes, or in some other way change it. But you've got to put that discipline into the system. I mean, without that tie back to the economics, I mean, you know what everybody wants. Everybody wants anything they can get that's free. I mean, everybody in this room would like everything you can possibly have that's free. And the only thing that makes most of us reasonable is it's tied in some way to not everything is free. There is some approach to it. I mean, all these discussions we have in this country about everything from end-of-life care to mammography has been in the headlines in the last year, to all the issue about how much free care should you get that's preventive in nature. All those are great discussions to have, and we'll make good decisions as long as they're tied back in some way to the cost of health care to the trust fund. If they're not, the answer is I want all the possible end-of-life care, I want all the possible mammographies, I want all the possible preventive care that I can possibly have. People are good at making these choices about things, and we just need to instill in it a system where there is a price tag of some sort attached to these things, and we can put medical care and our decisions about it in the context of the rest of the world. Here's all the things we could be doing in the public, with our money. I mean, we could be sending money to foreign countries. We could be supporting college students better than we do. We could be putting more money in education. We could put more money in healthcare. But to make those decisions, you've got to define what it is you're putting in and have the discipline to, when you change the rules, you change the amount of money that goes into the system.
Okay, we're going to take your questions in just a moment, so put on all your thinking caps. One last question from me, and that is, why do we go down your road as opposed to, say, a single-payer system like we have in most other developed nations?
Well, first of all, in a single-payer system, remember, you're really not in a single-payer system. You're not in any way breaking into this whole insurance. It's still insurance reimbursement. It's still a very old way of paying for health care. And when you look at Medicare is kind of a single-payer system. Its costs have risen more rapidly than the general averages in this country over the years. I just don't see it as any panacea. And second of all, in a single-payer system, you don't get this integration of the care. You preserve all of the cottage industry. Every hospital competes with every other hospital, and doctors do their own thing. And as we were talking about before, the Diabetes R Us clinic opens up down the street, and those things. That's the stuff you want to break through. When we buy a car, we don't go out and shop for the body in one place and the tires in another's and the paint in another paint shop and the steering wheel from somebody else. We look to somebody to integrate that thing into a package that makes sense for us. And then we make a decision. I want to spend $20 or $30 or $40 or $50,000 on a car. Different cars have different features, but it's all together in one place. And that's the sensible way to buy any complex product.
All right, I'd like to open up the floor to all of you.
I love that you take away the massive suction of the profit that goes to insurers and shareholders. I like the competitiveness of the systems of care. That makes a lot of sense to me. Briefly, I've beaten the current system by not dying and being very, very expensive to Blue Shield.
Well done.
I see you're doing the same.
Trying.
The causality of most of the things I went through was discovered 25 years ago. Had it been addressed then, I would have been very inexpensive to the system. Other than paying in, what motivates me to stay on top of things? We're getting fatter, we're getting more and more unhealthy. I pay into the system, but what motivates me to stay on top of it? Even then, when the causality was found, I didn't have it addressed because I had no insurance. Under your system, I would have the coverage, but what would motivate me to do it?
You're talking personal responsibility now.
Yeah, what's my responsibility other than paying in?
Yeah, it's a very difficult question, and when people have criticized what I've said in here, that's been the primary criticism. Okay, where I come out on it is I can't figure out how to integrate that in a fair and workable way. A couple of things I'd say. First of all, there's a lot of effort right now. In fact, health reform has in it the ability to change premiums based on whether you smoke or not. I've done the same thing. We did a program for small business in Tennessee, and we altered the premiums based on smoking habits and obesity and so on. But first of all, there's a fairness issue. If I do that, what about the person who comes up and says, well, that's nice. I understand why I have to pay more because I smoke, but Joe over here drinks way, way too much and has a couple of DUIs, and Susie over here skydives and scuba dives and all those things, and Sam rides a big motorcycle. So suddenly you're in the business of, there's lots of risky behaviors in the world. You're in the business of trying to decide what are the acceptable and what are the unacceptable risky behaviors, which I think is very difficult. And then second of all, we have a healthcare system in which we'll have, with reform, 80 million people in Medicaid, Medi-Cal, I guess it is out here. That's not a group of people in which you can apply any economic incentive to it. They can't pay they don't have health insurance without Medi-Cal because they can't pay the premiums. If they're obese, they can't pay an additional premium because of it. So it's a little hard to know how you bring it in. I just have sort of taken the attitude of saying, look, there's lots of reasons for you to be healthy. You want to live a long time. You want to feel good. You want all those kinds of things. Maybe the role of the medical care system is to say that's fine, and if I need help in doing it, I can ask for it. And if I get sick, they'll be there to take care of me. When you talk about the quality system, a good primary care quality standard would be measuring for finding out those kinds of things. I mean, I presume at some point you visited doctors for physicals and that stuff did not get picked up. That's the kind of thing you want to build into. What is a physical exam when you're 30 years old, and what are the things that really ought to be looked at?
Are we talking about a required physical exam, 6 months?
Well, I'm not suggesting that the government ought to say that you need to go get a physical exam every 6 months. I mean, at some level, we're Americans and we're independent, and we can make some decisions about what we want to do. I mean, if you choose not to engage with the healthcare system, I guess you are free to do so. But if you go get a physical exam, there ought to be a set of standards that says a physical exam when you're 30 years old ought to include these kinds of things, and if you find these kinds of things, it ought to include at least advising you as to what you ought to do about it. If I'm way overweight, I ought to get some advice about that in the system. This stuff is all taking place now at the front end, where it's this front end stuff, I should say, is not the profitable part of medicine. We all know of all the flight from primary care into the specialties. One of the things that I want to do with this is just to push a lot of the emphasis back to exactly the kind of thing that you're talking about. One other, just about the thing you said at the beginning, one other quick remark, and then I'll stop. Insurance companies, I don't, have any great. I suspect they're about as good and about as bad and about as greedy and about as altruistic as any other industry segment.
I beg to differ, but go
Pardon?
ahead. I beg to differ.
Oh, well, okay. And this is California. I mean, it may be different here, but it's remember that I made the point in here that the profits of all of the Fortune 500 health insurance companies taken together were less than the profits of one pharmaceutical company in the year that I looked at. So while you're looking, let's look for villains everywhere, but let's also remember that there's lots of people making a lot of money out of this system besides the insurance companies. If you want to start figuring out how to keep the cost of health care down, there's lots of places to go in addition to the insurance companies. It's very productive to do that.
I work for one of those healthcare companies that you mentioned.
Yeah, so you're to blame. Okay.
No. When addressing reform, have you considered the role that nurses play in healthcare reform? That's really not my question, but my husband told me to be brief. So what I really like to know is, for your model, you must need to work in order to pay into this or get health care. And because if I'm a housewife that's never worked, but I'm a high utilizer of health care, how do I get serviced?
No, I'm saying, first of all, with regard to that last point, the point I'm making is that we're going to provide health care for everybody, whether you're a housewife or you're very poor or whatever. The only place to pay for that is from the income of people who are engaged, in some fashion. So I just see this as if you work, you're paying in. If you're not working, you're not paying in. But every American, as a fact of being an American, has the right to this voucher. So in other words, if I have, in my particular case, I have a wife and a child. If my wife is not working and my child's not working, that's fine. They're entitled to the voucher, and part of what I do when I'm working is to pay for it. Now, that's no different than is going on anywhere else right now, because if somebody is on Medicaid, it is the people who are working and are paying taxes who are, who in essence are paying for that. So no, I see this as as I said earlier, if you're walking and you're breathing and you're an American, you're entitled to the voucher. And when you're working, you're paying for it, and when you're not working, you're not. So, when you get laid off for some period of time or something like that, well, fine, that's fine. Your health care continues, and when you're back working again, you're going to pay for it. If you're somebody who's living on investment income, fine, that could be a component of the way that we pay into this. And second of all, about the nurses, there are two women in my life, my wife and my daughter-in-law. My wife is a nurse, and my daughter-in-law is a nurse practitioner. I am a total believer that one of the ways in which you improve the healthcare system is to start moving a lot of this stuff out into these ancillary kinds of practitioners, and away from the notion that unless you have an MD after your name, you're not entitled to do this. I think any system of care that really is trying to work on things like some of these front-end things is going to make very heavy use of nurse practitioners, for example, and others in accomplishing that.
What you've shared so far sounds actually pretty revolutionary. And given where we are with the health reform that's been enacted, how do you see your concepts kind of informing where we are? Or is writing the book, has it been more of just an academic exercise for you?
Yeah, I wouldn't call it an academic exercise. I enjoyed writing the book, and I love talking about healthcare, but I'm a practicing politician. I was the governor for 8 years. I was the mayor of Nashville for 8 years before that, and that's my political career. I had been involved through the NGA with health reform in the
National
sense,
Governors
I'm sorry,
Association.
National Governors Association, in that they asked 4 of the governors, 2 Democrats, 2 Republicans. I was one of the Democrats, to work with the Congress to sort of inform that. To say that we were not welcome would be an understatement. Basically, the answer was in the Congress, nobody cared what the governors thought and had no interest in meeting, had no interest in hearing, and so on. And what we got reflected the perspective of basically a bunch of staffers, primarily Senate staffers, some advocacy groups that are in Washington. And that's an important set of perspectives. There's some very smart people who worked on this. But this is a big country, and there's lots of other perspectives about health care out there. I mean, I thought, for example, that some people who actually had run a hospital or actually run a, for that matter, run an insurance company, ought to have been involved in the thing, because you bring some kind of real world touching to this that's a good other perspective. So I just said, look, this is a thing that needs other voices in it. In my particular case, I've been in healthcare in the private sector. I got very involved with it in the public sector in several different ways. I got a different view of the thing, and it's up to me to not criticize what they've done, but to sort of say what I think's wrong, but move on to say, here's some alternative ways of looking at this. But what this whole book is about is saying you've got to have I hate the word, it's almost trite, you got to have a paradigm shift here. I mean, we really can't continue forever on the path that we're on. So let's talk about what that would be. What's a different way of looking at this? I think that in moving from here, there are some things you could do. For example, I talk at some length in here about this quality measurement, quality system. If you did nothing more immediately but put into place a real robust quality measurement, quality, standard setting and quality measurement system, that would be transformational in the healthcare system in this country. It then empowers. Maybe the way I propose to pay for it isn't the right way, and some of these things of pay for performance everybody's talking. It empowers all that. It just puts fuel in that engine and gives you the ability to do that. So I actually think something like setting up a quality assurance system would be a great first step on the thing. It takes some time to do, get you set up. I mean, sooner or later, we are going to have a reckoning with this. We're not going to borrow money forever from China. As I said, we've got a $37 trillion unfunded liability in Medicare. Medicaid is going to get worse and worse as time goes on. I'm sure it's a problem here in this state today, as it is everywhere. There's going to be a reckoning. And when that comes, we should have been working on some of the pieces that it's going to take to deal with it when it happens, and setting up a robust quality system. You can change the payment mechanism of Social Security tomorrow with the legislation. Setting up something like a strong quality assurance thing takes years. So fine, let's get started on it. If we go in the direction I've described, it's an essential component. If we end up going in some other direction, it's hard to imagine a modern system that really works for Americans, the patients rather than the providers of the care, that does not involve some sort of a much more robust quality system.
Has anyone from the Obama administration contacted you about the ideas in your book?
I've had some conversations with people, yes.
Anyone we know?
I don't think this is the appropriate forum to talk about
it's just
private
us.
conversations.
What, like I'm going to put it in the newspaper?
Your system addressed catastrophic illness.
Well, I think it handles it very, very smoothly. I mean, there are people who are going to have catastrophic illnesses through accidents when they're younger and things like. But these are the things. I mean, if the catastrophic illness you have is that you come down with some form of cancer, I'm suggesting there is in this red book some sort of a standard of care for that form of for that form. The system of care is obligated to provide it to you. They may do it directly. They may have contracts with people to do it with, but I think they've got to be handled. I think it'll be handled perfectly smoothly in this system.
But the Red Book wouldn't have the potential for some doctor who knows about some experimental treatment that might work. How does it accommodate that?
Well, I think what you've got to do is, as I said in the Red Book, I think you leave considerable discretion to the part of the professionals. I mean, I don't want doctors doing cookbook medicine on me or anybody else. But, a lot of times with this stuff, the real frontier is there's a huge impulse on the part of doctors to do a lot of stuff. I mean, there are cancers, prostate cancer is a good example, where the overwhelming feeling is people are much too aggressive about treating it and the kind of treatments that they do. And second of all, there's lots of places where there are various treatments at various cost levels, and there's no evidence that one is better than another. And the natural inclination is to do the expensive ones. I've talked about one example in here. But, it's also important to not occasionally there'll be some outliers, and there'll be something like that, and we can certainly figure out some exception process, but not to let those get in the way of the basic stuff we need to do. I mean, the costs in healthcare are in, these chronic illnesses, these acute episodes where you come into the hospital with your chest pains and you do those things, or an accident. We can set standards on these things. We can say what is good care. And I want to emphasize that when setting these standards, it's not, I think it'll help the cost tremendously, but the other side of it, it's about quality. I mean, if I go in with something wrong with me, I think it's reasonable to ask that if there is scientific evidence that A is better than B about treating this, I'd like my doctor to use A in some way to guarantee that happens. Yes.
So I like the way that you focused on the quality assurance piece. And what I know about healthcare is that the data standards are broken, and that there's special interest control of the data standards. So today's evidence is based on data standards that are politically controlled. For example, the American Medical Association controls the current procedural terminology and doesn't provide the same level of data measurement for nursing or allied health or ethnic and minority health care. So today's evidence is based on flawed data. How do we deal with issues like that? How do we transition from flawed evidence into a true quality assurance system?
Well, I think I'm not sure that I understand exactly what you were saying there, but in the what I've suggested in the book is that what this red book ought to be is not a prescriptive set of details of exactly how you treat X, okay, but rather a dashboard, to use the trite term, for what are the things you're going to measure. In diabetes, for example, what is I'm blanking on the name for a moment, the blood level measurement, the
A1C.
A1C. What is the A1C measurement, and is it within the ranges we think are right? Do you get these kinds of exams? Do you get this kind of help? That data seems to me unambiguous. I mean, in a medical record, you either did or you didn't get the eye exam. Your A1C is either 7 or above or 7 or below, and you have those things. One of the things that strikes me so much about the data and the information systems is I don't know any other sector of the economy anywhere in which you have to pay people to use data systems. I mean, the reason Boeing uses them is that they design better airplanes, and if they don't, Airbus will and will get all the business. I think the fact that and I've been very involved with this, the fact that in order to get people in medicine to even use data systems, you've got to set laws and rules and reimbursement changes to get them to use it, is just evidence of the fact of how messed up the economic system is in healthcare. In the system of care stuff that I'm talking about, I mean, systems of care are going to use data systems internally, because without that, they will not be able to compete with other systems of care, and they'll get low quality scores if they're not doing it. The thing that remains to be done, I think, is to just define a national data interchange standard, so that if you move from system A to system B, your records can move with you. If you get in an emergency room in Nashville when you live in California, the information is available to you. That's not rocket science. I mean, that's something that can be done in today's world pretty straightforwardly.
And there you have it. We have solved the healthcare system.
One last question. You've been an elected official, a mayor, a governor for 2 terms, and headed a publicly held company. At the Drucker School and in the works and teaching of our namesake, it seems to me one of the problems with trying to solve the healthcare problem is management and leadership. Any advice? I mean, what are the challenges? What are some possible ways to accomplish something? It seems the the debate is more about handing one party a defeat than it is solving a problem. Any insights?
Well, I mean, obviously what's going on in Washington today is not functional. I suspect we've been through it before, and we'll be out of this at some point in the future. You know, I think I've been an admirer. I read Managing for Results back, I think, when I started in the business world, and it was hugely influential on me. And it seems to me that one of the things that one of the essences of what Peter Drucker was saying to people is the importance of just with products or anything else, of delving into the real core of the problem and figuring out what are the right things to do. I guess it's the old saw about, you don't do the wrong things more efficiently. You find out what are the right things to do with the product. And that's really what I'm saying about healthcare here, which is, we can fool around forever with cookbook solutions to this little problem or this little problem or this little problem over here. We've just done 500,000 words of it in health reform. I think you need to step back. I think Peter Drucker would like the notion of stepping back, looking at this thing from a different perspective, thinking about, first of all, just the economics of it. I mean, economics drives a great deal of behavior. How do we line up the economics of healthcare behind getting what we want, which is good value? I mean, high quality care at the lowest cost possible in the healthcare system. We've got a long way to go, but until we see it in those terms, I think we're still going to be wandering around in the wilderness.